Thank you, Dr. Rakesh. So, first of all, I would like to thank the organizers of Diabetes India for yet again calling me and, of course, making me a part of this forum. It's a very unique one, and I should really say it's. So, to begin with, I'll be talking on the clinical inertia, which will be the silent killer in diabetes care. So, already know that the diabetes is a hidden epidemic. So, while diabetes affects 100 million people globally, an invisible crisis lurks within the crisis itself, and that costs lives, money, and of course the future impact. So if you look at the statistics, we're already familiar with them. 537 million approximately living with diabetes. These are figures from IDF Atlas in 2021, and they are projected to rise to 783 million by 2045. And majority of them, almost 90% of type 2 diabetes accounts for all diabetes cases globally as well. So if you look at the growth projection, it is almost 246 million, and this is a huge rise, unexpected rise, which is going to be there in the next 2 decades. Now, the growing crisis is mostly unseen. If you actually see, behind every statistics lies a person waiting for care that should have been started yesterday. And the national statistics in India also shows that majority of the patient, despite of newer therapies available, they are not adequately controlled in terms of blood sugars. So what is clinical inertia? It is the failure to initiate or intensify therapy when treatment goals are unmet, and it is a dangerous delay, if you see, that allow blood sugar to remain uncontrolled, and this silent phenomena leads to prolonged and sustained hyperglycemia in a lot of cases and preventable complications that devastate patients' lives. So if it is very important that we initiate an therapy in a timely manner, in a more pathophysiological driven way rather than a glucocentric way, because the guidelines are suggesting us. And this has been the main aspects which we need to target once we talk about clinical inertia. Now, looking at the problem in US.
Sorry to interrupt you. We have Dr. Naresh who has come here in the Indian attire. So we welcome him, and I'll just introduce Dr. Naresh here. So Dr. Naresh is involved in primary care, diabetes and obesity society of UK. He's practicing in South Manchester, UK, and has over 17 years of clinical experience. He's a community consultant in diabetes at the Manchester University Foundation Trust. He's a champion diabetes UK clinical champion, and he has been the clinical lead for diabetes in Greater Manchester and East Cheshire. He's a key contributor to diabetes strategy for Greater Manchester with integrated care systems. And he's been a board member of the South Asian Health Foundation. He's actively involved in training. He's a regular speaker at national conferences, and he's also a director of Vision Beyond Autism for supporting children and young adults with autism. So with those few words of introduction, I request Dr. Naresh to join us on the dais. And my co-chair, Dr. Manoj Chawla, is also joining us.
So can I continue? So thank you. So just resuming from where I left, so almost 50% newly diagnosed type 2 diabetic patients remain untreated with anti-hyperglycemic agent in the first year after diagnosis. And it's been seen that almost 75% of the untreated patients remain without therapy for even 5 years post-diagnosis, accumulating to major damages which are usually irreversible in nature at times. Now, the deadly consequences we already know of clinical inertia doesn't just delay the treatment, it steals future, destroys organ, and costs lives and billions of healthcare expenses. And if you see, the price of delay can really increase the heart attacks and stroke incidences, the high rates of heart failure, preventable emergencies and interventions, and the cost, be it in US and India, are pretty high. Now, the legacy effects are important. Early control can save lives. We have already studies, important landmark study like UKPDS already demonstrated that intensive early glycemic control reduces the microvascular complication by almost 24% over 10 years, and every month delay increases the long-term risk dramatically. The time lost is the lives lost. That's what we call when early treatment is one of the important factors behind the success, and the window of opportunity for preventing complication closes rapidly with each passing month of inaction. If you delay and there's inertia, so that leads to long-term complication, in fact, the lives lost. So why does clinical inertia persist? Let us understand the complex barrier that prevent timely treatment in the first step towards breaking the cycle. Now, there are multiple levels which are involved where the barriers come into play, and they can be provider factors, patient factors, and then the system factors overall. So, if looking at the provider factors, the fear of hypoglycemia has been one of the important reasons because of which they've been not initiated in a timely manner on particular therapy. Of course, clinical uncertainty, of course, they have been there, although the guidelines have made things out very clear. Even the recent guidelines, be it ADA, ASD guidelines, even the RSSDI guidelines, they are pretty much eased out, and they are talking about how to initiate therapies in recently diagnosed diabetes. There have been overworking workload, of course, as we talk about the Indian subset of patients, which actually, again, is a big challenge in initiating the therapies, of course, in the early course, and that, of course, leads to barriers as well. So patient factors can be the denial of diagnosis. A lot of this thing has been seen that the patients do come to the clinics, but they don't agree that they are having diabetes. They keep on denying that they are having diabetes, and that's how it also leads to an inertia. Fear of injections can be one of the another factors because of which the insulinization has been delayed. And even despite the GLP are there in the market, a lot of patients do believe that even they are also injectable insulins, because of which sometimes we have to spend a lot of time in convincing them as well. Low health literacy is, of course, another big challenge, especially in a country like India, where we actually have to take into account all these considerations and the system factors, which is a fragmented care delivery system, limited access to specialists, insurance authorization hurdles are major concerns once we talk about a country like India, where the barriers are there in terms of as far as inertia is concerned. So hypoglycemia is the main driver. If you talk about the physician hesitation, 3/4 of the physicians cite fear of causing dangerous low blood sugars as one of the reasons for delaying treatment intensifications. And new continuous glucose monitoring technologies can really be very useful and can offer hope to overcome this critical barrier by giving up a good real-time safety data. Now, if you look at statistics from other countries as well, be it United States, UK, Canada, Brazil, and Spain, the clinical inertia as global phenomena which affects diabetes care across healthcare systems worldwide, and it is pretty high across all areas of globe. The human stories behind the data can be something which can be illustrative of, and it can tell us how these different cases are important and what can be done. So if you take a case example, a patient A having diagnosed with diabetes at age of 58 years, left untreated for 5 years, and then he went on to develop heart failure, diabetic retinopathy, and this really increased the healthcare burden cost phenomenally. There can be another case where another patient has started on metformin at diagnosis but never received therapy intensification despite of persistently elevated A1C levels. So A1C remained above targets for years, leaving this patient at high risk of complication despite being treated. So although the patients were treated, he was inadequately treated, the intensification was not done, and this has led to long-term damage, of course. So every delay has a face, and behind every statistic about clinical inertia is a real person, someone's parent, spouse, child, or friend whose health hangs in the balance. Of course, that's been one of the, again, important reason why we really need to take into account the caregivers as well once we start the therapy. So breaking the cycle of inertia is a very important one. It's a vicious cycle. Understanding the problem is very important, but action is essential. Sometimes it requires caregivers, a team approach, paramedical staff, diabetic educators, of course, the dietitians as well. There are proven strategies that exist to overcome clinical inertia and save life as well. And what are the available strategies? What we already talked about. Proven provider education, performance feedback and guideline training the clinician, of course. That's something which is very important. That's been done time and now, of course, in order to educate the primary care physicians in order to initiate the treatment and don't delay it. Patient empowerment is another factor where diabetes self-management education and shared decision-making has been really advocated time and now. Integrated care approach, which is a multidisciplinary approach in terms of clinical decision and support tools, they are also advocated, and that can be one of the important strategies to overcome clinical inertia. Now, the era of innovations can definitely make a difference, but in a country like India, there are a variety of treatment, and there's a huge gap in the healthcare because CGM is one of the important useful techniques which can really reduce hypoglycemia instances, but the use is actually limited to only certain parts of the country. New drug classes like SGLT2 inhibitors and GLP-1 receptor agonists offers a CV benefit beyond the glucose control, and telemedicine and digital health often helps to remotely monitor this, but they are again limited to certain areas of the country. They cannot be generalized. These are useful innovations, and in times to come by, even the governments of India are taking certain necessary steps in order to make changes of that sort. So policy and system level solutions, there can be insurance reforms, of course. We have reforms for the Indo patients in our country in form of Ayushman Bharat Yojana, wherein the diabetic emergencies, urgencies have been actually treated, wherever else the Abha Yojana is also under provision, who can really offer a certain kind of respite for the outdoor patients as well.
Abhishek, will need you to wind up, dear.
Yes.
Right?
Of course, and then provider incentives, awareness campaigns are usually done, so that call of action is really important. So we stand at a crossroad. The knowledge exists at the clinical inertia, and that is what we need to act upon. The cost of inaction is too high. It can lead to human toll, millions of problems, complications, surging up, and economic burden as well. So ending clinical inertia is a shared responsibility in terms of both clinician, patients, and the policymaker. And early, aggressive, and sustainable diabetes management can save lives. Thank you.
Thank you, Abhishek. And let me just remind everyone here the format is on each of these important aspects, we will have our speakers speak for 5 minutes, the international, the global Indian perspective on that over 5 minutes, and then we would like to open it up for Q&A for 5 minutes. So that's the format for each of these topics. Each topic is extending to 15 minutes, 5. Thanks, Abhishek. And now we invite Dr. Naresh to speak and give his opinion on the clinical inertia.
So, sorry, Abhishek, for interrupting your talk. I think I just want us to have a 5-minute discussion. So, I listened to most of your talk. Sorry, I wasn't there. And I was just going to try and point out a couple of things that you brought up. One is the topic of clinical inertia, what it means. I think you talked about it, about failure to start therapy or its intensification or de-intensification, but at an appropriate time, right? So we agree on that. You talked about this as well, improvement of glycemic control. But one thing we look at is what is the importance of reducing inertia in terms of costs. So in patients with HbA1c less than 7% continuously for 1 year, there's a 25% overall diabetes reduction in diabetes-related treatment costs, medical costs, and also lower pharmacy costs as well. So those are big things. But this is what you were touching upon, I think, right? About therapeutic inertia is complex. We think at least this 30% is because of patient-related. And what do you think those reasons are then, seeing as you're here?
Yeah, it's pretty much close to that. So it's patient-related, close to 30 to 40% of the cases.
Yeah. It says 50% is due to HCP. So you can see we are a bigger contributor of inertia than more patients are. I think with regards to patients, one of the things we don't do is inform them about the about what their condition is, so they lack understanding and they don't know why they're taking therapies. And if they don't know why they're taking therapies, they're less likely to take them. So in Manchester, we had this mantra that is no medication without education. We're trying to make sure that patients understand why they're taking it. But from healthcare perspective, I think you and I are on the same thing about competing demands, very busy, non-stop, everything is going on. And then I think we have a lack of knowledge. We don't understand it, we don't treat people. And we can always say, well, it's Diwali now, it's Christmas next and everything, just leave it for another 6 months, it carries on. And also the healthcare problems that we talked about is they're not individual guidelines. Guidelines are not individualized. We just treat everybody the same. So that's one of the big issues there. Anything else? I mean, you talked about this as well, right? About why we need to be treating early. This is Kamlesh Kunti and Sam Seidu's data. And with this one thing that I want to show is about earlier and appropriate intervention may improve patients' chances of reaching the goal. The black line is what we normally do. It's called treating when we actually failed. We attempted treating, right? But if you did something sooner, moved everything to the left earlier, you're more likely to get a better HbA1c and reduce the legacy effect. Anything else you want to add about this, or before we call it?
Well, absolutely
Extra
the same
questions?
thing. Oh, no doubt about it. Absolutely.
Okay. Manoj, we're ready for some questions.
Thank you.